son used to work with me. And she's new. And she's new since September. So I told her that not to.
Where are we sitting, sir?
Oh, okay.
A little bit somewhat of a delay, but I'm sure you understand that right now the nation and the world is really consumed with the issue of Ebola. So that was one of the issues that was the subject of the prior event that was being held in this room, as far as educating hospital executives, I should say, as well as clinical clinicians, on some of the issues surrounding Ebola. But nevertheless, thank you for being here this evening. I know you didn't necessarily come here to listen to me, certainly the panel, which is I'm extremely grateful for having, but you probably came for some of the wine from Casa de Vinos and the delicious food that we'll have later. Many of you already know, but it never hurts to get the word out, to give you like a little bit of a historical perspective on who and what is the work of AHE. We've been around for, next year will be our 15th anniversary. Thank you. I don't really have like a special name, like Sesquicentennial, or a special name. We'll have to think of something. But nevertheless, we've been around for 15 years. And if anyone ever says it gets easier as time goes by, they're not telling you the truth, because certainly with this whole transformation of the healthcare scene, it's caused strains not only on the provider side, but certainly on membership health associations. So we've had to kind of think out of the box. How can we provide the same quality programming and initiatives that we did when we had a little bit more money? Because as again, all of you know, if it wasn't for the support of our national partners, Aetna and Greater New York Hospital Association, our regional partners, North Shore, LIJ, Healthplex, Casa de Vinos, I'm going to forget others, Health First, we really couldn't accomplish our work. So during the last 15 years, we've had the opportunity of developing the health workforce pipeline. I'm glad there's someone here from Mount Sinai, so they can hear me talk about what we're doing and how we can engage Mount Sinai in some of our initiatives, having their Latino employees more involved in our mandate. So not only do we obviously have a board of directors, but we have a managers council, and Clara, where is Clara? Clara's there. Clara's our current chair of our managers council, and we're hoping to groom, where's Patty? There it is. So we're trying to groom Patty to take over so that Clara can join the board. So that's kind of the way the pipeline works. We also have, and Paul, don't go away too far, come over here so they can, you have your spotlight for a moment. So Paul Bousquet. Paul is our new fellow. He's our first fellow, and he helped coordinate this evening, and he'll be talking a little bit later. So, we've looked at how do we put together an organization that's meaningful in the 21st century. How do we keep up with technology? What associations offered in the past is a little bit different than what's happening today. I like to tell everybody that our footprint is tri-state, New York, New Jersey, and Connecticut, but our impact is nationwide because of our digital exposure with using Grupo Parada as our digital media company. So we've been able to videotape all of our events and have a presence on Facebook and Google and all the other social media networks. So we're getting ready for our annual awards in June. There are two initiatives that I do want to announce this evening that we'll be launching by the end of the month. One is the Jose Pepe Morales Mentorship Program. So what we wanted to do was to look at how we could select 6 to 8 mentors and give them a mentee for a 6-month period of time, an intensive mentor-mentee relationship. So we're going to be sending information. I think you received information in your package about the mentorship program. We're going to be expanding that, and so I guess one of the questions is, you know, who in this room wants to take the role of being a mentor? Because at some point in most of our lives, there was someone there that helped us get to the next step. So now it's your turn to help younger people get to the next step in their professional careers. And yes, if you're a woman, a person of color, a member of the LGBT community, it's difficult, a little bit more difficult getting to the next step. So we're putting the word out, we need mentors for our students, whether they be undergraduate or graduate students. So I hope that you'll either speak to Clara or speak to me or speak to Paul about your interest, help us get the word out. We have the fact sheet and some other back page collateral information, which we'll be sending out to our listserv by the end of the month to get interest in it. We'll be working with Paul, going to the career services departments of all the colleges and universities in the area that have master's, MBA, MPH, and other MPA-related programs to let them know that we had this mentorship program. So that's kind of what we're doing in the background. So we're continuing our events. We're expanding our digital footprint. We are continuing a 2-year discussion on the Affordable Care Act and how we can enroll more individuals in the Affordable Care Act using vehicles other than the traditional print TV vehicles. You know. So this event this evening is to look at how do we address digital media to capture those individuals that are 35 years and younger, or as I think Health First said, kind of middle-aged too. So we're not just looking at younger. You still didn't capture me yet, you know, so you have to go past the middle age. So the younger ages. So we're going to be put together a great panel who I will introduce shortly. But right now, it gives me great pleasure to introduce you to someone that you probably have seen around for a while because she has been in public service for many years. She coincidentally served on Community Board 7 while I was on Community Board 7. No, we didn't have any arguments, I don't believe so. She went on to bigger and better things, serving on the City Council, specializing in IT. She is a fierce advocate for small business, housing, education, and she's certainly getting her baptism as Borough President. So I'd like you to give a very warm welcome to our new Borough President, the Honorable Gail Porter.
Thank you. It's a big honor and very humbling to be here tonight because I know a little bit about technology, not a lot about healthcare, and I'm very intimidated by all those young people who know about both. But what I want to do is just talk a little bit about what I love, which is the relationship between community development, technology, and you know, healthcare is also technology, community development, because we're all trying to improve people's lives and improve our neighborhoods. So I had a couple of experiences this morning that I thought would be helpful, because one of the issues, I was chair of the technology committee in the City Council, And 2002 is like light years away. That was like decades in tech world. And I remember when I came in, I'd always been interested in technology, whether it's for healthcare or government, making sure that information is available, obviously making sure that anything personnel is not in the public sphere, but trying to get information out. So I worked in the Dinkins administration, worked in other city agencies, and I was always trying to let the public know what's going on. I even remember putting kiosks in front of City Hall in the early 90s to say, look, all these events are taking place in City Hall, and this is how you can find out. So I always want to get information out. So when I became chair of the technology committee, we actually went on a 5-borough tour. We went several times to different boroughs and had hearings about how people could use in 2003, 2004. That was like eons ago. I mean, people were using dial-up. They were still running lines to the payphone. You know, it was a whole different world from, I don't think we even had wireless. It was a whole different world. I mean, it was very slow. You would go to a small business on Flatbush Avenue in Brooklyn, and they couldn't download the video fast, which they needed for their business. So, and then of course the good news was I passed the open data bill, which has really revolutionized, I think. It was the first open data bill in the country, and still the first one that's passed legislatively. The federal government has one. But it says that the city of New York, all agencies, have to put into the open data portal, which is just nyc.gov/data, all the databases of the city of New York. Now you might think, don't we already have all that information? To the credit of the Bloomberg administration, they passed it with me, together with the city council, and I think they liked it better than I did, because they didn't know what their agencies had. This is such a big city, 80 city agencies, 300,000 employees. You don't know all the databases that exist. So fast forward to 2014, the 2 agencies that people really want. Health department is quite supportive of these efforts, but the police department, oh my gosh. So during the Bloomberg years, and I like Mayor Bloomberg, but they did not release any data to this portal. And to the credit of the current administration, they are releasing, and not only are they releasing, they're meeting with the good government groups and the groups that work on technology to what should we be doing? What databases would you like? The crash data, what kind of crash data? Because sometimes the 2 agencies don't have the data that can talk to each other, so it's hard to get something clear. So I gave you all this because I really want that data to be out there. Because, talking about communities want to know, community boards want to know, neighborhoods want to know, what's going on my block? What's going on health-wise in my neighborhood? And believe it or not, even though you work hard to tell them, they don't know. This is such a big city. So if you're able to, again, we're going to have enough data through this portal. We're going to be working with the communities in Manhattan to provide staffing, because you can't do this as a community-based organization without somebody helping you build the map, doing the overlays, doing some programming. You can't do it alone. So we're going to help the communities do that in Manhattan. And you'll be able to know, although you might know what the situation is on 116th Street, I can promise you people don't know. And they don't really care about 82nd Street, understandably. They want to know about 116th Street. So we're going to work on that. And I hope that as a result, people will say, listen, we really do have a problem here. Because they read about it, they hear about, you know, a neighborhood, but they really want to know about what's going on environmentally, health-wise, obviously police-wise in their area. So hopefully we're going to use the open data information to be able to do that. So I just want to say, as a overarching issue for my interest and agenda is to accomplish that. Easier said than done. We're working on some grants. We're working with CUNY students to train them to look at the 311 data, to analyze it, and then be able to share it with the community board. So that's one aspect of, I don't know whether you call it, digital health, but it's an aspect that I think the public is looking for. Second thing, just in terms of what we're doing is, in New York City, I met somebody today who said he was the author of Digital Divide. Isn't that like Gore saying he founded the internet or something? I don't know. But this guy said he founded Digital Divide. Okay. But it was a great conference. It was in Harlem. And Silicon Harlem is trying very hard as an organization to bring more tech to Harlem. But one of the issues there, which was interesting, is that, whether it's jobs or trying to figure out how, again, this information can get out there, I'm sorry, people are very anxious for this kind of information. And what was pointed out was that the big companies, whether it's Microsoft or Amazon, the consumer from the community of color is huge. There are very large numbers of community of color, as George has pointed out, for all products. Almost no people of color in any of these agencies, in any of these companies. And so that came across today loud and clear in terms of technology. So we need to change that because people are buying these products but not being part of how they are developed. So that brings me to the schools, because we talk about young people. One of the issues in the borough of Manhattan, and in fact all of New York City, is that I think somehow we got caught on not having programmers, not teaching coding, not doing the current job opportunities being taught in the schools. There's a guy named Fred Wilson who's a venture capitalist, and he's trying to change that by actually paying for these types of teachers to exist in the schools. But that's not how it should be. The schools should be doing it as part of, organically, their teaching program. So today, I was in East Harlem, 50 principals show up for a discussion. Every single one of them comes up to me with their technology problems and requests. Now, I know DOE is trying. I know they have 1.4 million students, 1,400 school buildings, I don't know how many thousands of teachers, etc. But if you talk about young people wanting to get access for their information and how to do it on a general societal level, people have to have the skills not only to be able to get the information, but to be part of how to create the information on a software, hardware basis. I was at Google recently, and as I shared with George, they are actually funding to quite a large extent a group called Black Girls Who Code. This is a group out of San Francisco, and they are using on the after school, thank you very much, thanks so much. After school and on the weekends, they're actually doing what I suggest, which is going to Google. They have a huge turnout of young people, and they are teaching them to code very quickly, and then they're building their own apps. So in healthcare, and I know you'll have much better speakers on this than I am, but in the healthcare world, if you want a healthy society, you gotta have, in my opinion, that kind of input that then produces the kind of results that you're also good at doing. So I like to think we're ahead on everything. I don't think we're ahead on this issue at all. And we have two problems. One, the schools have very slow apparatuses. Sometimes the equipment is old. One woman told me today as a principal she had to close down the computer room lab because she needed it as a classroom, so there are 0 computers in the school. And another person just said that everything is outdated. This shouldn't be. If you're gonna keep up with, in our case today, talking about healthcare, then that has to be current, because that's where the kids are gonna learn, and that's where their parents are gonna pick up as to what they're doing. I wanna talk about seniors. It's a horrible statistic, which you already know. There'll be more older people in New York than under 18 very soon in the 5 boroughs. I hate that statistic, because I'm one of them. But it's true. So the fact of the matter is, at this conference today, with people from Washington, people from overseas speaking, there were panelists all day long at Harlem Silicon. There was a couple of folks who are international in their, they basically are VCs giving out money around the world for innovative technologies. You always wish you were one of them. Why didn't I think of this? You listen to this panel. Why didn't I think of this device? Why didn't I think of, whoever's made $1 gazillion yesterday? Well, seniors seem to be the place that the devices are focusing, whether it's for your, hearing devices or, this guy was a little obnoxious, because my father's 94, he can run any machine. This guy seemed to think that all seniors can't run anything. But I suppose he has, I'm being a little facetious, I suppose he has some points, because seniors do take longer, but they want to communicate for health reasons, and they want to communicate in terms of grandchildren. So I know that groups are working with them to try to improve their computer skills. But the tech world and the inventive world and the investment world looks at what will make money, obviously. They are all out there looking at devices that can help seniors. This gentleman had a long list of about 13 startups that he is invested in to see which one is going to be the one, whether it's the one button you push to reach your child, your adult child that can come help you because it's complicated if something should happen to you. All those worlds that to me are, why didn't I think of that? And then of course somebody else did. But the point of the matter is, just in terms of health, the seniors are a population that the investment world is looking very carefully at. I want to mention also language. I know it's a healthcare issue in the sense that hospitals have to translate, health communities have to translate. We have 103, I think it's 183 languages in New York City. We just had a meeting with the African task force that I sponsored on 116th Street. And the obvious issue there, of course, was Ebola. But the other issue is there's a wonderful new commanding officer of the 2-8 precinct. She's the first African woman to head up a precinct in the city of New York. Her name is Inspector Obi, and she's fabulous. She speaks a dialect. Obviously, she speaks English, she speaks French, and she speaks a dialect. The woman sitting next to her from the same country speaks a different dialect. And she said the other day she checked on the language line that the city pays for, and after 3 days, I believe she said, somebody finally called her back and said, I found somebody with a dialect. Now, is that going to work if you have a heart attack and you are on the no, I don't think so. So this whole issue of language, parents won't go to a school board meeting unless their language is spoken there. I think Spanish is often translated, but all these other dialects that are coming in, nobody there to speak. So again, how can technology, you would use it in the health world. I think about it in the health world and in the school world, because I want parents to be involved. They're not going to come if they have no understanding of what that teacher or principal is stating. So I know some horrible stories now with judges. Judges have the same problem. They got a case, can't find the translator. There is a translation service available, but the person's not available. So what they do now, which scares the dickens out of me, is they write Google Translation. They write, will you be available on Wednesday? Then it translates into Urdu, or whatever language. They pass it over to the plaintiff or the defendant. They say whatever, and they pass it back. That is really scary. Now, if they don't, thank goodness, I hope, conduct any hearings, any court appearances in Google Translation, I hope not. But I'm just saying this whole issue of language, as we have more and more languages and dialects, a lot of the Mexicans coming here, as you know, speak different dialects. They don't even speak Spanish. We need to work on this, and I don't know how technology and healthcare can play a role, but I know on the ground, I hear about this all the time. Even applying for public assistance, there are 5 mandated languages if in that neighborhood, 25% of the applicants speak the language. That's how HRA determines if they will put a translator into that community. And I don't even know how some of these even work. This is what's on the books. I can't tell you that it actually works like that. So the issue of how do you deal with language. Another thing that we want to do more of is what I call civic hackathons. What is this? I've been sending community board members to civic hackathons and they think I've lost my mind. I love civic hackathons. This is a nice meeting, George, but I love civic hackathons. And what that is these technologists sitting in a room just like this, thinking about the issues that you care about. You know, how can we get more members who are low income to go to our service? Or what is it that is of interest to a group of young people regarding healthcare? And the problem is presented, and then a few weeks later at the Civic Hackathon, which is all technologists, like packed, the room is absolutely packed, they come up with an app, they come up with some ideas. Now, Gail Brewer sits there, what the hell are they talking about? Because it's not always embedded in the kind of reality that we know. But this guy came up the other day at one of them. He got a big award from the mayor at the big apps festival on heat, on hot water. Right now, the inspector shows up, you hope that you're home, you hope that the thing isn't working, if you've called the 311, and then the paperwork goes back to City Hall, and maybe you get a letter. I mean, it's literally, you get some emails, but it's very slow. So he has this device, you stick it in your apartment, and in real time it tells you whether the heat's on or off. It's much more complicated than that in reality, but it's a start to think about innovatively using technology, how we can change the way we think. And I think in the healthcare world, particularly in public health, we need to think more creatively about how young people who are thinking about why isn't this happening like this, or why can't this be done differently. We've been measuring the curb cuts on Broadway because we want wheelchairs to be able to go up and down on the curb cuts. Okay, so we have a stupid measure, you're not gonna believe this, we have a tape measure. So somebody says, Gail, just take the iPhone and measure it. So things have to change, and in the healthcare world, there's an app for that, as you can imagine. As young people say, Gail, there's an app for everything. I say, yes, but it doesn't always work. So I just want to say that I'm certainly not the expert on anything that you do, or how on a hospital or healthcare world the issue of technology is making a difference. But what I want to do is kind of share some of the ideas that are out there and some of the thoughts that are going on, some of the processes, whether it's the New York City Tech Meetup, which has 1,200 people once a month at every meeting and 800 people on the wait list. So the issue of, and they're all about what they're like a big civic hackathon. They want to know how to solve societal problems using technology. And I think as a group, young people are always part of it, whether it's high school students, that's really depressing. High school students coming up with really great ideas, none of which you understand. What are they talking about? Or it's college grad students or people who are just thinking about this as part of their everyday lives. And I think when I think about, we have, in the past 5 years, we have committed in this country $33 billion to digitize our nation's healthcare data. And since 2010, we've invested $13 billion in mobile and digital health ventures aimed at building apps to promote health. So I've given you, you know better than I whether some of these are working, some of them aren't. I think this is definitely an experiment, and some things work, some things don't. But I try to outline some of the problems that absolutely have to be solved if we're going to have the kind of society we really want. So I would like to say thank you for including me. I think in terms of the Affordable Health Care Act, there's lots of opportunities for young people. It's changed a lot in terms of kind of health care that they can get and how you do it in a way that involves them so that they can be part of it, be healthier, the society can be healthier is what we're all about. I try to outline some of the issues that on a bigger scale we're thinking about in terms of in New York City in terms of healthcare and technology. Thank you very much.
I know she usually has like 3 or 4 events an evening. I just wanted to find out from the panel, is there any questions you wanted to present to the Borough President?
Come on, you guys. You know more than I do about
How about
this
the audience? Any questions now?
Go ahead.
Or forever hold your peace? Jill,
Thank you very much.
So I see that Aaron Smith, right? Aaron's co-founder of Young Invincibles, so he's joining. So before let me just quickly, now that we have the full panel here, just introduce them, and then I'm going to go back and add just some remarks from our fellow and our national partner. This evening, we have with us Pamela Mattel, Chief Operating Officer for Acacia Network, to my right here, who will be discussing successful strategies to engage underserved populations. We have Aaron Smith, co-founder and senior strategic advisor, Young Invincibles, why expanding the ACA coverage to millions of young Americans is important, and ways to communicate to this segment. What I had cause for you. Unfortunately, Nasri Michelin isn't able to join us tonight. He was called up to Albany to the New York State Department of Health, but in his place is Fabrici Banfield, who will be discussing consumerism and the evolution of more affordable insurance products and technology to improve education around affordable care and increasing engagement. Marcelo Rodriguez, who will be discussing, Marcelo's at the end there, President of Group Parada, how do we use digital media to enroll and educate young adults? And Errol Pierre, who's AVP Product Management for Health First, talking about experience with reaching young, underserved adults. So you'll hear from them in a moment, but just let me take this opportunity to reintroduce Paul Bousquet, who is our new fellow, and just kind of give you a little bit, talk a little bit about the mentorship program. So, Paul.
I really hate speaking in front of people, so just bear with me as I say and like and all those things that you hate my generation saying. To start, I graduated from the University of Miami in healthcare management. I took a year off and I was at Columbia for a year studying to go to medical school, which I chose not to pursue and get back into healthcare management. I've been with George and Ahi since the summer, and I'm their first project coordinating fellow, and my task has been to rejuvenate the Student and Young Professional Committee, which is a pipeline for talent to the Managers Council. So I've been working diligently all summer, and we are excited to announce the Jose Pepe Morales Jr. Mentorship Program. The program is going to get students from the Manhattan area, retargeting career centers at NYU, Columbia, Baruch College, City College of New York, and other schools within the area that have a strong presence in healthcare management, to have their students apply, both undergraduate and master's students, to receive mentors in the field of healthcare management. The program is going to last 6 months. Our flight program application begins November 1st for enrollment in January 2015 through June 2015. In addition to receiving mentors, the students are also going to have to complete a project. Projects are to be determined, could be for the mentor, could be for the organization, or it could be research, whatever they prefer, that'll keep them enrolled in the mentorship program. The program is really set to create these students to join the Student and Young Professional Committee to prepare them for director level positions in the future. One scary statistic that was told to me was that 30% of New York City is Latino, if not more, and 20, if not rising, percent of the nation is Latino, yet only 2% of all executives in healthcare are Latino. So I think it's really important that we prepare students today to take on the challenges that they're going to face tomorrow when they do become directors and CEOs. And it's important to really refine that talent to handle the challenges that we're all going to face. So I encourage any of you, if you're interested, to be a mentor to a student, to reach out to myself or George. My information is on those sheets that are floating around, and I would love to hear from you, your story, if you had a mentor and what you learned from your mentor.
So we'll say questions for the reception time with Paul. So I'd like to just have, before we have the panel come up, is have a few remarks from our national partner, Aetna, Fabrici Banfield.
Thank you. Good evening, everyone. How you doing? Everyone's awake? Good, good, good. Well, I'm going to have time to speak about my topic, consumerism, but before we begin, I just wanted to thank you all for coming out tonight. You could be other places. It was raining this morning, and we were able to negotiate with Mother Nature to bring the sun out so that you can come out and join us tonight. So, I want to thank everyone again for coming. I want to thank the panel for putting this together. The association it's very important that these types of events continue to happen, regardless of how small or how large. As long as we continue to participate in them, that's one extra person that is educated on the topic, and that goes a long way in accomplishing all of our goals. Aetna is proud to be a sponsor, a member, a constituent of all of the things that not only this organization, but many organizations around the city and the country do. And we hope to continue to build that partnership. So if you have any questions in relation to how Aetna can better partner with you in educating people, especially of underserved communities, feel free to share your information. We are interested. All right, thank you.
I would be remiss, and I don't know where he is, but we have here this evening also Luis Vasquez. Luis is the chair of the National Hispanic Chamber of Commerce on Health. Luis, you there? Okay. Oh, there you are. Okay. So one of the things that Luis and I are doing is venting applications from women, minority-owned small businesses that are interested in being vendors with the Greater New York Group Purchasing Organization, the GPO. So Greater New York Hospital Association, which represents hospitals in New York, New Jersey, and Connecticut, is looking for qualified women and minority-owned businesses to do business with their healthcare facilities that are members. So you can outreach to me, go to our website, my email is there, give me a call, see me on the street, come to a community board meeting, I'm always there, and talk to me if you know of any qualified vendors that might be interested in completing the application. So I want to thank Louis, who is chair of the Chamber on Health. He's also, by default, and as part of his reign, the chair of our awards for next year. Yeah, he doesn't get out of it. I just reappoint him no matter if he wants to or not. So I really appreciate it because we get to see a lot of venue sites to see which are the most economical to use and do a lot of fundraising. So I appreciate for his work and certainly for the products from Casa de Vinos that he provides at our reception. So thanks, Ayola. Without further ado, I'd like to just introduce Pamela Mattel again, Chief Operating Officer of Casa, and she has, I believe, a PowerPoint presentation for us to see. Pamela?
So I'm glad to hear that Aetna has the power to change Mother Nature. Anyway, good evening, everyone. It's really a pleasure to be here. Some of us got that question. I'm really happy to be here to share with you a little bit about what Acacia Network, who we are, and what we're doing to help really engage the underserved community, particularly Latinos, in right now in the South Bronx, but we are statewide, including Florida. We've expanded to Florida and also to Puerto Rico. So Acacia Network, I'm sorry for that little glitch on the slide. This is our mission, and it's very important to us when we're thinking about reaching out to the communities. Partnering is a very important aspect for us, as well as leading change with really the vision to promote healthy and prosperous individuals and families. Acacia Network is the second largest Hispanic not-for-profit in the country, and we're the largest in New York State. That is, we're very proud to talk about that because 5 years ago, we were a group of small organizations. Some of you may have known Basics or Promesa, organizations that exist in New York for quite a long time. We came together 5.5 years ago now, because we believed that there was strength in numbers, that collaboration and partnership, succession planning amongst community-based organizations would be critically important as the trending went on. And I think that really came true as we're seeing what's happening in New York State. We've worked on something called the the Acacia Health Neighborhood, which a lot of what I'm going to be sharing with you this evening is based on. And I think you'll find that what I will share with you is nothing that's profound or hasn't been thought of before, but I think hopefully you will understand that there's a great drive and mission to really operationalize a lot of what people are talking about in terms of engaging communities. So some of you may know that the Bronx has some of the worst health disparities in the country. We have the lowest or near bottom for all of the health social determinants. We have a high rate of unemployment, poverty, violence, highways. Unfortunately, the Bronx is really challenged with an enormous amount of vulnerable communities that are really trying to pull themselves up and faced with lots of barriers and access issues. The young man mentioned that the growing population in New York and the country really is the Hispanic population. And one of the things that I think is important for us to recognize, particularly with this population, is that Hispanics are much more likely to be engaged in social media for digital opportunities. And actually, Hugo Prada taught me that a couple of years ago. And then we really have launched many different opportunities to engage people through social media. One thing that was very important to us, and perhaps it's a slide a little bit later on, is to is to really recognize this very important piece that in order to engage people in general, but particularly the Hispanic culture, that when we take a one-sided approach that as healthcare providers we're experts or that we have more information than the people that we're serving, it really puts people out and doesn't necessarily engage them in understanding how they are really the partner and the driver of their own healthcare and quality of life. And many things that we've been doing have been turning the decision-making and engagement from the C-suite, of which I represent, back really to where it belongs, which is in the community on the street. And that is what helps to drive a lot of our decision-making. Acacia Network is really trying also to be the voice of the community, which is very important as the ACA continues to roll out, as healthcare transformation really takes on a much faster pace. So some of the things that we've been doing and adding more to are outreach vans that are out in the community, not only bringing healthcare out to the community, but also asking people for their opinion and not asking them to come into the office to tell us what they need, but for us to be out there and having them tell us exactly from where they're living. We've instituted a lot of the other things that are up here on the slide. And one thing that was interesting that I found, just as a matter of course for myself, because we have 1,800 employees, I used to be able to say I knew all of our employees when we had 135, but the 1,800, it's really a stress for me to remember all their names, even their faces. So I started doing a weekly email just from my office out to all the employees to tell them what was happening. And what I heard was that the clients wanted access to that email so that they also knew what I was thinking and what we were doing. So we've expanded that weekly email so that clients also have access to that information. One of my best stories is on the way from my office to my car, there's an apartment building where we have supportive housing for people with HIV/AIDS. And there's a gentleman there, Charles. He did not know who I was. I was really happy about that, other than I worked at Acacia Network. And so every day when I would leave, he would stop me. We would sit on the stoop together. He would tell me how the weather is, and then he would chat with me about what was good, bad, and different about Acacia Network. So I learned so much from him and his perspective. And then one day he came to a meeting, and there I was speaking, and he said, "Oh, now I know who you are. Now I know how to get things done." So he calls and emails me all the time, not just to share information, but to request things. So good for him. 4 things that I want to share with you that I think are relevant to really engaging the community, particularly that we've found to be incredibly successful. The first one is to market this idea of Acacia Answers, or Request a Acacia. And that is really our digital campaign to make our website a lot more user-friendly. We changed our format so that it is now easily picked up on any kind of mobile device. And we're continuing to make improvements with it. We have gotten ourselves on Facebook, Twitter, a lot of the other social media markets, and have people trying to keep the content up and fresh. We also get a lot of feedback from Facebook, from people in the community about things that they would like for us to do more of, so that we really appreciate that kind of bi-directional communication. And we started a video campaign where we have been videoing some of our staff on different health topics. I have a video that I did that I didn't really like that much, but my group put it up on Facebook and our website, and apparently 8,000 people saw it. So it's out there. I'm looking to see if we could redo it, so I might like it. But apparently 8,000 people saw it, so I don't know if that's good or bad. We do an Acacia News network, and Lane Falcone, who is actually our development director, has another career as a newswoman, and we post this in all of our health centers. So there are different tapes that are running, telling the patients about different health topics, about opportunities in Acacia Network for them to connect to. Because the network has 3 major areas: primary health care, behavioral health care, and housing. And one of the things that is incredibly important to us is that they are all integrated, and access into one includes access to the other 2. So if I just go past this a little bit, what we found in 3 months was, with our online health video campaigns, that was just in a 5-mile radius of our main campus, that over 60,000 people viewed those videos in just a few months, which is an incredible amount of people. When we're talking about engaging the community in their healthcare and understanding ACA, videos and the visual really is a very entertaining way to pull people in. I want to talk in another way about using digital to engage people in their own health and have them feel more empowered around making improvement. And there's a tool called the M3 Clinician. You can look it up on, if you put it in your web browser, M3 Clinician. And it looks like this. You can pull it up on your iPad, and it has, I think, 21 items that ask you questions related to 7 different mental health disorders. And a person themselves can self-administer this, and it then kicks out a profile of where your symptomology is. And if you're also putting in other information about your medication and your visits, it also tells you a lot of other information. And we now use this in almost all of our sites: primary healthcare, behavioral healthcare, and in our housing shelters. And very interesting, what we have found is not only are people, the health providers, becoming a lot more sensitized to the co-occurring disorder of primary health care and behavioral health care, but we are finding that the score has engaged people in a very different way. So this last thing, the last note here, is that we overheard clients sharing their scores and encouraging each other to get a better score. And we were very excited about that, because it normalizes the conversation about mental health disorders that is so stigmatized that people really want to stay away from. It is integrated into our electronic medical record, so it's shared throughout our organization, and the clients really enjoy it because they have the power to answer it. And we administer it with them over time so they can also see how their behavior and their symptoms are changing. Another thing that we did that we're also very proud of to engage the community is this year we chose Comprehensive Asthma Wellness Project as our major operational aim. The Bronx is really facing an incredible epidemic with asthma, and many of the people we know are ending up in emergency rooms for visits and for rescue that could really be done in primary care and closely monitored, I think a little bit more efficiently in the home. So this was our big aim, to really address asthma. And typically, the way that we have done projects before is there's a group of providers that meet, we look through evidence-based practice, we come up with a good intervention, we go forward. And this time we decided to really stick with our walk the walk on engaging the community. So instead of starting at evidence-based, we started with the community. And we did 3 community health forums. We invited people from all over, from the bodegas, from the subway, from the supermarket. We had these health forums that had refreshments and entertainment. We had, as you can see maybe over in the corner there, newsprint. There were several questions that people sort of took a path through, spent some time, answered the questions, told us what mattered most to them about asthma and treatment and quality of life. And from that feedback, then we've gone back to the literature to find what matches what matters most to the community. The last thing that I'll share with you is something that I'm not necessarily proud about, the first part, but the second part I am. In April, we found that in 4 weeks, we had 6 unsuccessful opioid overdoses on our property. We have a very large methadone maintenance program as well as substance abuse. But 6 overdoses in a period of 4 weeks is very scary, even 1 overdose. They were unsuccessful because our staff was able to intervene and apply the medication that reverses the overdose. And so we got together to talk about why are all these overdoses happening and what could we do to make a difference. And again, instead of trying to figure it out from our perspective, we went to the community to talk to them. And what we ended up doing based on their input was to create what we called the Clay Avenue Center of Excellence. And it involved a lot of aggressive community education because people were talking about they didn't really understand what was happening. They heard about it in the newspaper, but gee, this was really in their own community now. So we did a lot of education, and then we totally changed the physical environment. And we made a very large effort to turn what had looked more like an institution into a hotel lobby. And the clients, of course, loved that because immediately they feel more dignified that they're coming into something that looks like maybe a Marriott than a substance abuse or a primary health care clinic. And their behavior began to change very quickly, and they asked for more and more to ensure that the environment that they were walking into was really respectful of who they were in their heart and soul, not necessarily representative of their socioeconomic status. And since then, they have created a community advisory board and have also, you can see here, they created peer ambassadors. So these 2 people in the vests are clients who volunteer to stand in the waiting room, and they greet everybody who comes in, and they help navigate through the building, but they're there through lived experience, through volunteer. On the back of the vest, it says the Acacia Answer Team, and they meet regularly with me and the senior managers to continue to provide us with input about what they're seeing in the waiting room. So very quickly, after all of that, there still are a lot of challenges and barriers to ensuring that some of these ideas really take hold throughout the whole community. And we recognize that we have also been part of the problem as the community, as the providers, in influencing the way the community uses healthcare, which is the emergency room. We know that the emergency room is open 24/7. There is a perceived reputation that emergency rooms have that you get better care than you do in your primary care doctor's office. You can also get all your lab tests, all your x-rays, everything done immediately. And that's not what can happen in primary care. So we understand that this needs to shift. And the other piece that's also important is that through all the efforts that we're doing in New York State is to move out of the silos between primary behavioral housing and really integrate those things together to become incredibly collaborative in a way that we have never really thought about before. So I really thank you for your attention. I look forward to hearing the other panelists. I'm sure that with all of this, there will be a great amount of conversation for us to engage in. So thank you very much.
As a footnote, I always enjoy Pam's presentations. They're so organized. She's so comfortable using her iPad.
There you
You know,
go.
so she's.
So I'm a digital convert.
I actually have a question for you. I'm looking at the logo of Acacia, which is a tree, right? And can you give me the story behind why the branding of a tree?
I can. I hope that the rest of the audience wants to know as well.
Yeah.
So very briefly, the acacia tree is endemic to many of the countries in Africa. I will get to how it also translates into Hispanic culture. But it has many different connotations. So one is in Africa, it is a self-sustaining tree. It provides fuel, shade. It is able to dig very deep into the roots to get water, which is very representative of Acacia Network with our roots deeply embedded in the community since 1969. It is apparently the tree that was used for the covenant of the Ark. It is supposed to be the tree of the burning bush, so there are those connotations as well. And what really made it for us to select the logo is that the flamboyant, which is a tree in Puerto Rico, is also part of the acacia family. And it's very beautiful. It has red blossoms on it. And so because Acacia Network likes to perceive itself as a self-sustaining effort for the community, we felt that the tree, because it is so beautiful and represents so many different aspects, was a good logo.
A little bit of history. We always like to put that in our healthcare discussions. Thanks very much. We are here also joined from Washington by Aaron Smith, the co-founder and senior strategic advisor for Young Invincibles, and he will be discussing the ACA coverage to millions of young adults is important and ways to communicate that to the segment. Aaron, welcome to New York. You want to stay there?
Yeah, it's
Okay, that's fine.
Hi, everybody. So my name's Aaron Smith. I'm co-founder of a group called Young Invincibles. Very excited to be invited to participate in this. I'm based in D.C., so I took the train up for the day, but I always like coming to New York. My family is in Yonkers, New York, and we have an office here. And this conversation about serving underserved populations, particularly underserved youth populations, is something that we're extremely interested in and we struggle with, frankly. So a bit about Young Invincibles. We were started back in 2009 when I was a student at Georgetown Law School to make sure that during this huge debate about the Affordable Care Act that young people had some kind of voice. It was, there's this perception that young people don't care about our health care coverage or our health care. In fact, that's where the term Young Invincibles comes from. It's an insurance industry term. And we sort of wanted to turn that on its head because in our experience, young people did in fact want coverage, but millions of us have jobs that don't provide benefits. We don't make very much money. We're unemployed. whole range of reasons why young people don't have coverage. So one of the first big things we did was we worked with Nancy Pelosi's office to introduce the part of the law that lets you stay in your parents' plan to 26, which New York actually already had something like it, but across the country, about 3 million young people have been able to gain coverage because of that provision. Unfortunately, young people are still the largest group of uninsured in the whole country. Even after the dependent coverage provision, there were about 19 million uninsured young people. Much higher rates among young people of color. So, young Latinos, almost 50%. Young African Americans, about a third, are uninsured. The Affordable Care Act is doing more to help, young people get access to coverage than really anything in our history. And so our challenge is, how do we reach as many young people as possible? So we serve as navigators in some states. So we have navigators here in New York, DC, Virginia, and California. Last year we ran for the open enrollment something called Healthy Young America, which was a national campaign to educate and enroll young people. We were active in several dozen different states. We did a number of interesting tactics to try to reach our generation. So, for example, we did a White House Youth Summit last December where we had about 200 young people, young influencers, I'd call them, from around the country. So it could be DJs, young entrepreneurs, student body presidents, young people who had clout in their community from a diverse array of communities, who weren't necessarily from the healthcare community, where many of us are from, but who could speak to a broader audience. And out of that came this idea for something called National Youth Enrollment Day. So on February 15th, we did over 100 events around the country under this banner of National Youth Enrollment Day. All the events were different, tailored to the local audience. So some of the events were at comedy shows, some of the events were with local sports teams, some of the events we partnered a local DJ with a local community health center. Basically anything we could do to be creative to get young people engaged, because we know that healthcare is not the sexiest topic, but it is something that a lot of young people care about. We also did a lot of things digitally, and I know that's an area of interest. So, for example, we partnered with the Department of Health and Human Services, and we did an online video contest where young people could submit their videos about why healthcare coverage mattered to them. So it was a way of crowdsourcing content rather than, and we find this all the time, rather than us sitting in a room trying to figure out that, really catchy message for young people. Young people know what that message is, and they have ideas about it. And I should say, because it's such a diverse generation, one message might work for one group but not work for another group. You really have to have a sort of a multitude. So we put this call out. We actually put up cash prizes. And we had a huge response. Over 500,000 young people participated online in that campaign. Some of the videos that were submitted had over 100,000 views. And again, it was just crowdsourced. It wasn't us trying to come up with, some brilliant idea. Here in New York, we're actually going to be launching a project this fall, specifically looking at dreamers and how do we do a better job of getting healthcare information to dreamers? So both, looking at documented youth and some of the coverage options they have. How do we get them access to Medicaid in New York where they can actually get it? But also undocumented youth. How do we do a better job of getting that information? So we're going to be doing focus groups. We usually start everything we do with sort of a listening tour. So that'll include talking to partners. We'd love to talk to you guys and others who work with this population all the time and can give us advice. So that's going to be an exciting project. We're also we built a mobile app because, as was said, young people are very much into, getting information through their phones. And so we're starting to think about what happens after coverage. So it's going from enrollment to actually getting care is a real challenge. And how do you make it so that young people, when they get coverage, don't just rely on the emergency room, but are actually using primary care and actually accessing preventive care? All the things that, are good about the law that people who sign up, even after we walk them through all the process, might still have no idea about how to actually use their coverage. So trying to figure out, we're using a mobile app, how to sort of expand that healthcare literacy for the newly enrolled is going to be a huge part of our challenge. And then this year, again, we're going to have a huge push around open enrollment. It's a tighter window. We are going to be doing National Youth Enrollment Day again in January, so that's something to look out for. Excited to hear what other folks are working on, and also happy to answer any questions. We work with a group called Voto Latino in DC. That's the main national one. I would love a connection there. I know our New York organizers have sort of a network of folks that they're reaching out to. I don't know if they've reached out in Staten Island, so. Okay, thank you. And I would say that I think the Dreamers are also some of the most inspiring organizers, period, in the youth movement right now. Yeah, absolutely. we're in. Yeah, absolutely. We're excited about that.
Thanks, Aaron. So we're going to have a Q&A after the panel. So let me ask Kabuchi to talk about your consumerism and your other issues. Please.
I'm going to try to use some technology here.
There it goes. Okay. Give it a little time. Now open it up.
Minor technical difficulties, nothing we can't get through. So I wanted to spend some more time focusing on this one topic called consumerism. I want to emphasize that this is not the solution, but just a solution to what we can introduce to some of the young invincibles, some of the people who are even on insurance today that are dissatisfied. It's a new way of looking at how to offer insurance that I won't call it new. It's been around for quite some time, about 5 to 10 years, but it's still relatively new for a lot of the people who have used insurance for the last 40 or 50 years. And as we look at how to introduce some of these new people into the marketplace of insurance, this might be a new way to grab their attention and engage them so that they can have a positive experience and continue on spreading the word and getting more people involved. All right, I got it. So a lot of this is ethnocentric, and I'll try not to make it too much ethnocentric, but a lot of it still applies to any type of insurance company that you're dealing with. I had a cousin call me yesterday saying she is uninsured today or has Medicaid today and is looking to go to the private market, and the first thing that she wants to know is which company she should go with. Not necessarily the first question I would encourage her to ask if she was looking for an insurance product, but it is something that people want to know. When they're looking online, they go to healthcare.gov or they go to any sort of insurance site where they're shopping for benefits, they're looking at the company name. And if they're going to do that, they should look at company names that are dedicated to improving the lives of the people who are participating in their programs, which I have to do a shameless plug and say Aetna is one of those institutions. So we definitely want to put the people who use our services at the center of what we do, and everything that I'm about to talk about, whether it's Aetna specific or not, is something that we truly believe in and think that as people use the benefits, as people consider Aetna, they should consider that the organization is committed to their health insurance literacy. So the first step is defining what consumerism is. And this is a little bit tricky because everyone kind of has their own definition. But think of it as shopping for any type of product that you buy today. Whether you're buying shoes or buying anything online, you shop around for your benefits. And traditionally, what health insurance was about was you get these benefits, you pay a copay, and you look the other way without knowing the true cost of the services. And because that has been the traditional way of approaching the benefits, the cost of health insurance has gotten a little bit out of control and unsustainable. So as we revert to a method of how we shop in our daily lives, and we sort of integrate that with health insurance, we're going to see, we think, a lot of people saving money in the long term, but also becoming just more engaged in the healthcare process overall. So, and this is a little bit broken because of the PDF version of it, but as you can see, I tried to illustrate what the old method was. It's the doctor says do this, the patient says yes. I think the city of New York ran or it might have been HHS, a while ago ran a commercial about questions are the answers. And a lot of that is still resonating as we try to get people to conceptualize what that actually means. When they go into the doctor's office, don't submit everything that the doctor says. Not that they're not educated and they're not professional enough to be able to give you the right information, but you want to engage in a give and take. You want to share what your experiences are and what you think the issue is, and then have that discussion with the doctor so that they can also provide some better recommendations. And that's a little bit of what the new method is, and the idea of consumerism is. It's really engaging in that process and collaborating with the doctors and hospitals to improve your care. So as we move on to what that actually means, that means that consumers are going to have to start thinking about, well, are they going to the right doctors? Are they choosing the right doctors to provide the best care for themselves? How are they choosing the doctors? Is it just a doctor around the corner who happens to be local? Well, we at Aetna think that it's important that we provide the tools for consumers to be able to navigate through the provider system. There are many, think of Yelp. Yelp is a platform that allows people to rate their experiences for any type of service at a restaurant or anywhere that they might want to go. Not that we want to be that platform, but we want to at least give some of the members the tools to be able to know that they have choices. They have some choices, and this is the exercise that they should be engaged in. Now, a lot of this is, after you capture the young invincibles' attention, what do you want to tell them? This is the kind of thing that really gets them involved in the process, so that once they're enrolled, it's not, well, what happens now? So we as the health insurance company really has taken on the responsibility of providing some of these tools so that they can have a better experience, not only in choosing the health plan, but after they're enrolled. And this really translates into savings for them. So usually you don't know, I talked about, well, you just having to pay a copay, and you not knowing what the true cost of those services are. What we've done is taking that a step further and really try to engage the members into looking at what the cost of services are, what the quality of that service is, and encouraging other people around them to take advantage and be smarter consumers. And that was just a little graph about being a smart consumer. So there are two types of consumerism-based products, and I'm not going to go into the details of those products, but I just wanted you to get the concept of what that is. And it's essentially the member taking more financial responsibility. If they know that they have to pay for benefits out of their pocket, it's not going to be a copay. If they're shopping just as they shop for any other commodity for healthcare services, we think that they're going to be more engaged in the process and go to not only more cost-efficient providers, but put pressure on on our partners to make sure that they're providing the best quality care for them. And this is a graph showing a little bit about what our research shows. So the purple being a full replacement of that consumer-based product versus the traditional style in the, I'll call it teal color. As you can see, there is going to be a significant savings over years if someone adopts this model. And again, this is not the solution, but just a solution to how a person who is not familiar with the traditional style of insurance can come into the market and feel a part of the process. We want them to be a part of the process because if they're a part of the process, they can help be a part of the solution. So I wanted to give a couple of examples with those different types of products where, it is their financial responsibility to pay for services. Does anyone know how much a regular doctor's office visit costs? It probably costs around $80, $100, right? But yeah, it depends. A regular doctor's office, a primary care physician will say where you're not doing any extravagant tests, because that adds on to the cost of the visit. But the idea of being on a consumer-based product is you're going to have the ability to see what those costs are. So what Aetna has done is we've created the technology for people to be able to go online prior to going into the doctor's office and seeing what the cost of that visit is, and then navigating how they want to spend the money that's either allocated from their employer or the money that they saved in the premium by going to this consumer-based product. So it's the idea of them now taking a little bit more control over what they're going to be doing on the product and having that same type of experience, I'll say it again, as them buying any type of other product online, the shoes, the hats, whatever it may be, it's the same type of feel. And there's different components, and everyone kind of has a responsibility in that member engagement aspect of the consumerism idea. So there are incentives. A lot of what I do at Aetna is employer-based offerings. So we always encourage employers to say, okay, well, if you go online and you complete your health risk assessment, which will just give you a scorecard, which they have no access to, but it will give you an idea of what your health risks are. If you complete that, we'll give you a $50 gift card. People who know what their issues are will have a better conversation with their doctors, and that will improve the process. It'll ensure that that problem, if they have one, they may not have a problem, and that's fine. But if they have one, it'll make sure that that doesn't get worse and add to a much greater cost issue. As some of you may or may not know, healthcare costs is one of the leading causes for bankruptcy. So we have to look at this as a financial issue as much as it is a health issue. And then we talked about the member tools that Aetna offers. We have a lot of tools that are specific to Aetna members, but a lot of what we're trying to introduce now is, well, if you're not an Aetna member, whether it's because our product just costs too much, or whether it wasn't offered, it wasn't available to you, we want to still give you some tools to be able to navigate through the healthcare system. And we do that. And then, of course, the product itself, which, again, I'm not going to focus too much on. So the tools that are available, the Aetna Mobile, the Aetna Payment Estimator, are two tools that are available to Aetna-specific members. The Payment Estimator is the most important tool, in my opinion, because that's the thing that's going to get people to choose where they want to go. But the last bullet is iTriage. And this is a very unique tool that's I call it agnostic. So you don't have to be an Aetna member to be able to download this tool. So if you have an iPhone, a smartphone, the task today is to download it. I'll be checking everyone's phone at the reception. But this tool is sort of a WebMD version, a WebMD mobile version where you have this avatar. And if you have a condition, and think about, people who might not have insurance. They go online, they'll Google a condition and see, well, is this something that I should be worried about? Well, we wanted to piggyback off of that, and we offered this iTriage tool just as a minor solution to getting some people engaged in the healthcare process. So you tap on your foot on this avatar, and something will come up. Every condition related to the foot will come up, and you'll see some things that might be of interest to you, and you'll be able to do some more research on it. People want to know what is wrong with them. So we think that if we give them the tools, they'll be more engaged in the process. There are other excellent parts of the app that encourages people to research about other healthcare news, things around them, but also encourages them to use urgent care facilities versus emergency rooms. Emergency rooms cost a lot of money, and you may not get the best service at the emergency room versus an urgent care clinic, which can treat you a lot quicker and cost a lot less to the system. So these types of tips feed through this system that's, again, available for any type of consumer. Doesn't have to be an Aetna member. And we think that that's important to the process. So as you talk to people who are looking for insurance, and you talk to people who are interested in coming into the private market, those are some of the things you want to talk about, the consumerism aspect of it, and these important tools that not only Aetna offers, but a lot of insurance companies do. Thank you.
Kabuchi, that avatar, you don't have one that's like one of the brain? Because there are times that I say, what was I thinking, And I would always like to figure that one out.
Tap the head, it's in there.
Marcelo, you are next. Would you come on up, please? Thank you.
Hello, I'm Marcelo Rodriguez. Nice to see you here. Those are some excellent points that everybody in this panel have done, and I think that just encapsulates what's when we talk about innovative strategies, community is so important because in our work in the experience we have is, yes, internet is a good media to outreach to young people. However, specifically talking about Hispanics, we like to transact in person, one-on-one. So the idea of merging the community organizations with the outreach of the internet, as Aaron was talking about, I think that's like the key strategy in general. I don't think it's really innovative. It's just like more of what we already know, that community-based organizations are the ones who can close the deal, and the internet can help us to outreach to more people. Now, I wanted to showcase this is because I was playing soccer like 2 weeks ago, and I still try to maintain fit, I guess. But what happened was that in this small, it's a small league, it's just entertainment mostly. But what happened is that they took all the levels, like all the categories, and they put it together in a match. So imagine what happened with us, that we are level 4 category, they are level 1 category. So they killed us completely. They were like very tall, very young guys, like they ran all over. And somehow I start thinking like, yeah, that's exactly what's happening with the healthcare industry. We are behaving as very slow, as we're not getting in shape when it comes to digital marketing. Why do I say that? It's because fast food companies, soda companies, they are killing it when it comes to digital marketing. When we talk about in general, like, okay, yes, we know Hispanics are online. Yes, we know we love to be on social networks. But the healthcare in general, healthcare industry in general, is investing very low when it comes to digital technology, digital marketing. Now, in general terms, when it comes to Hispanic marketing, only 5% is going to online. And from every industry, healthcare is the one that invests the least on digital technologies. So I think there is something that we have to start thinking about. If we are hearing all over and all over that young people, Hispanics from 18 to 35, are spending a lot of time there, but we're not making a lot of efforts to outreach out there. And our own strategies were great because it's what you guys do is to take the what you call them, the influencers. Online is about that, influencing influencers, the community who have a lot of followers, who have a lot of people. Now, as we're talking, as I was saying about the other industries, they are doing a lot on there. They are taking these influencers, but they are pushing their products and services. Now, this is very interesting because I've heard a lot about, yes, the Hispanic market is great, but Spanish is not, people who speak Spanish are not online a lot, which is a great lie because this is from Google. They made a research and they said, okay, let's take all the Spanish searches that are done in the US and they categorize them. And you see where is health? 195, close to 200% growth in searches in 2 years in Spanish, health-related searches. What that means is that we just, I'm sorry, from Edna? He was saying about people come and they do searches online, right? So Spanish speakers, we also do searches online, especially when it comes to healthcare, because there are not many sources of information. Now, when we see some reports this is a Google report, so they took all the searches in the U.S. in Spanish, and they put it in categories, and you can see that healthcare is up there. Now, the other part, the opposite side of that, is that the venues, the media in Spanish has not grown as fast as the searches are. So we have people searching for asthma related, like for diabetes in Spanish, cancer in Spanish, and health insurance itself in Spanish. But there are not so much information about that. Now, the reason why I'm saying this, just to give you an idea, if we take the top 5, the biggest healthcare companies in here, and we put it together, and we sum up all the, let's call the fans, the followers on Facebook, do you know what's the sum of those? All of them. Do you have like a number? It's almost 500,000 followers, okay? Now, if you take Pepsi, Coca-Cola, or McDonald's, you're talking about 100 million followers in Coca-Cola. You have 50 million followers in McDonald's. So you see that they are investing a lot. So yeah, in order for us to start connecting, communicating, sending them apps and start the conversation, we need to outreach to them. So yes, as Aaron said, healthcare might not be sexy, it's of course, but we need to make it sexy. How? Relevant content is the key. We don't mix the entertainment part in our information, and I think that's always the key, because we need to make it entertaining for young people to sit down and learn about healthcare, because healthcare is not only about being sick, is to be well, to look good, to feel good, and to do things that they want. So just to give you an idea, those are the big ones, right? So they sum up 500,000 likes on all over. And as I said, if we just measure McDonald's plus Coca-Cola, they are close to 200 million followers. So let's start thinking that as an industry, we have to start creating content, we have to start doing things. And I think a lot of us have heard about Facebook, right? Now, in Facebook, there's something that's called audience targeting. What that means really is if you want to reach out to New Yorkers in the age of 18 to 35 that are interested in fitness and wellness, and they are Hispanic, so how more relevant do you want to be? And do you know what's the potential right there? Close to 600,000 people that are right now on Facebook that they want to know about healthcare, and they are on that age, and they are right there. When we, what you can do is when you go to Facebook or when you see on digital media, look at how many healthcare ads are you looking at, how many healthcare videos are you looking at, and you're gonna see that they are not many, they are not relevant. We are not there, so we have to start working on content. So just to give you an idea, I don't know if they have internet here, but as we were talking about, what do we do when we need a product or service? So when I came to this country like 10 years ago, that was my only tool. So I came, I was staying with my family in the Bronx. I was close to Forum. So I didn't know anything or anybody here, and my family was very traditional. They came and they start working. They didn't learn English a lot. So when I start asking them what to do, they just said, "No, don't worry. Just start a restaurant job and then keep working, and then somehow you will do better." But as young people do, we don't rely so much on the family anymore. So we start researching. So what I did kind of was what a lot of people could do right now, which is they are going to maps. They are using their telephones. They are using their technology. So my first search was, okay, what do I do? What do I know? I know Spanish and I know computers. So I started looking for community organizations in the Bronx. So something I found was the Kingsbridge Heights Community Center. So that was my first gig in the United States because I needed to do something. I didn't have money, and what I did was I went to online and I did this search. So the idea that came to my mind was, okay, I go there and I'm gonna tell them that I know how to do websites, and I did their first website, so they allow me to start my practice there, but that was nothing in that time. And what I started doing is searching for community Hispanic organizations. That's how I found another Ecuadorian organization there. I connected with them, and then I found another organization. That's how I connected with George through another person. So everything I did was online. So now, moving forward, not to bore you, is what we're doing with our phones is just like this. This is live so you can do it on your own telephones. So some people would, even before knowing what they are gonna use or what provider they are gonna use, they're gonna do like something like healthcare, right? In New York. So as you can see, all that red dots are the companies that provide healthcare. Now, this is going to be interesting because Spanish speakers do the same. The only difference, I just want you to see how many red dots you see when I put healthcare, right? The Spanish speakers do the same. The only difference is that we put Seguro Médico, right? In our phones, on the, how many dots do you see there? So as you can see, there is a huge
Health first.
health first. Great.
There's only one. There's only one in New York.
Exactly. So what is that telling you? That the market is there. That you have the tools, you have the technology. That we are searching there, and as you can see, we need more information. The same thing we're doing here. You can look at bigger, like more bigger approaches in trends. Trends is a tool, an aggregative tool that will allow you to see bigger trends during a period of time. And I like to always see the Spanish part. And I want you to take a look at this. I am looking at Seguro Médico in the United States alone, and I want it in the past 12 months. You see when it was the peak, March, and if we can come and see from 2004, we will know when the spikes are. And this is important for you to start creating content, because when we said, oh yes, we want to outreach, we want to connect with the community, we need to be relevant to them. So when we're talking about what to do, what to create, what type of content we want to know, is you start typing and you start researching of exactly what people want. And this is a great tool that can help you figure out where you are. And just to finish this, you know what's the second largest search engine in the world? YouTube. So that means that people like me, when we didn't know that, and that's Google too, they bought it, they're gonna type ¿qué es un seguro médico? And if you're not on the searches, you have to start creating content, because as we just saw, people are interested in that, in insurance in Spanish, but the content is not there. So let's just start finding out more of these type of events. Let's share information. Let's create content, and if there is any questions, I will be down there. Thank you.
So, and lastly, Errol Pierre, please.
How's everyone doing? Marcelo, I'm glad we found you. You said you were Googling stuff trying to find us. I'm glad I found you, so that was amazing. So what I will do, because this panel has been amazing and with all like so much good information, is make sure I don't repeat anyone and only give information that maybe hasn't been shared or enhanced on what folks have said, because I thought this was a dynamite panel, you know. And I asked George to also talk about not just young invincibles, but also middle-aged, because what we are seeing is there is a big pocket of folks, I say middle-aged, you know, 30 to 50, right before 50, that are also looking for this knowledge and are using online tools as well. So I'm going to just broaden the conversation a tiny bit. I'm going to give you a 1-second preview of who we are. So Health First, we're actually, should be on the panel because we're only 21 years old. Well, we started in 1993, so we're young as well. We're a nonprofit organization. I spent the vast majority of my healthcare career at a for-profit organization. And one of the beautiful things, there's a lot of people either in the Bronx, from the Bronx, or close to the Bronx, Yonkers. One of the things that's beautiful about the Bronx, I live in Soundview, is Health First actually advertised in Soundview, and that was one of the reasons that brought me to the company, because they actually advertised where I live. So we're a nonprofit, and we're hospital-owned. We're actually in one of the hospitals that own us, Mount Sinai, and that creates a great partnership because their success is our success, so we partner together to make sure that our patients are as healthy as they can be. Thousands of providers, up to 24,000, access to care, The folks that work at our company in our four walls, about 5,000 of them, they come from 43 different countries. So there was a discussion about the different languages and the different dialects that was spoke about by the borough president. We can handle that. We can handle Urdu, and we can handle dialects in Bangladesh and different languages from Spanish because we have a very diverse population. And one thing that's awesome is 93.4% of our current members would recommend us to our friends or family. That's the most important thing. And talking about recommendation, even though the room seems light, on average, everyone has 7 friends. So we actually filled the room because everyone here is going to talk to 7 people. So the room is filled tonight. And then let me just spend 1 second on how we work. Because we're partnered with hospitals, we share in the risk. And what that means is if the members aren't healthy, both the hospitals and Health First don't meet our objective. So it's important that our members are healthy, which means any profits that we get from our health insurance, we actually give it back to our owner hospitals. So any profit margin that we're making on business of patients that come to Mount Sinai, come to this facility, at the end of the year when we true it up, we take our admin costs to run our business and keep the lights on, and everything in excess of that we give back to Mount Sinai, and they use that money to help with uncompensated care. People talked about people going to the emergency room. A lot of times they don't have health care. We give that money back to Mount Sinai so they can pay for those services, because a lot of times those services cost 3 cents to the dollar for the hospital, and we can obviously help out with that cost. So it's a great partnership, and it's funny, we're in Mount Sinai because we actually launched a joint Medicare product that will be live on January 1st with Mount Sinai. They gave us the providers. We will give out the ID cards, and we'll partner to insure seniors. Okay, my commercial's done. So here's the context of the conversation for New York. There's 2.3 million people uninsured in New York State. 2.3, it's a big number. 1.8 million are in what I like to call our service area, the 5 boroughs and Nassau and Suffolk. Since January 1st, 2014, 9,600 people enrolled. 9,600 people. A lot of that had to do with all of the efforts that people in this room did. We actually have, I call them pioneers. Just raise your hand. Ben, Jill, Abraham. These guys were pioneers, never did ACA ever in our life, and they were on the street explaining the Affordable Care Act in different languages, in people's homes, in Starbucks, explaining this, and the result was, of the 2.3, 1 million people enrolled for health insurance, which was amazing. 80% of the enrollees were uninsured at the time of application. Unheard of. So these people never had insurance before, or they had a gap in coverage. They haven't had insurance for over 6 months, and they're getting coverage for the first time. The beautiful thing about it was 55% got Medicaid. Medicaid is obviously a state-sponsored program for people who make below $16,000. So even without the Affordable Care Act, these folks could have gotten coverage before 2014. But what the Affordable Care Act did was take the signing up and put it online. So we talked about how much people do with searches. Because they were able to enroll online in the privacy of their own home, we got 55% of the 960,000 to enroll for Medicaid that they could have had before the ACA, but because of the ACA, they actually got it. A lot of times there's a stigmatism with Medicaid. These folks were able to do it in the privacy of their own home and enroll. If you look at the other percentage, 7% were Child Health Plus. No child in New York should be uninsured. And we actually found 7% of the people who enrolled got Child Health Plus. And QHP, which is the commercial, the private insurance plans, it was 38%. So I'm going to focus on the 38% because this is a new population. And that's the 370,000 that enrolled in what we call a qualified health plan. Over half got a silver plan. Really briefly, they did the plans like the Olympics. Bronze was the lowest, gold was the highest, and they even had a platinum plan which covered everything. And bronze covered 60% of your healthcare costs on average. Platinum covered 90% of your healthcare costs on average, and silver plans covered 70%, but there's actually additional subsidies that were available to lower income folks that could make a silver plan act like a platinum plan. So folks that made below $25,000 actually got a platinum plan even though it was silver. And so that it was a beautiful thing that we had most of the membership in a silver plan, which means their deductibles were low, their co-pays were low, their cost sharing was low, and they didn't have to worry about spending a lot of money out of pocket before the health insurer picks it up. And then you can see where the enrollment happened. Half of it was in New York City, and about 20% was in Long Island. So what did the people look like? This shows you Medicaid, Child Health Plus, the commercial plans, which is QHP, and all the programs by race. And I put a big red circle around QHP because it was a problem area. And why was it a problem area? If you look at every other column and match it to the all programs column, you can see that proportionately, they pretty much look the same. And there's a little asterisk at the top. The asterisk is that 21% of the marketplace enrollees voluntarily reported that they were Hispanic, just as a note, and 25% of the enrollees did not respond to the application of race. So someone could have said, I'm white, Hispanic, black, Hispanic, or other Hispanic, and that is cobbled into the bars. So the reason why this was a problem area is because if you see this African American bar on all programs, you see how high it is? Look how low it is for QHP. If you look at the blue bar, Asian Pacific Islander, look how low it is for QHP. If you look at the did not respond bar, look how low it is for QHP. And then even, and then here's the interesting thing, for white non-Hispanic, you see how high it is. It's actually higher in QHP. And why is that? The website was in English, and the language wasn't at an 8th grade reading level or lower. So folks that had higher level of education, higher income, signing up was easy. It was the folks that had a lower level of education, lower income, very complex situation because you had a multitude of plans that had a harder time. So while Medicaid actually is higher than the all program average, it's the qualified health plans, the people who make above 16,000 that are lower income and of a diverse background that actually are underrepresented in enrollment. And so that's where we're going to focus on. So for us, Health First target audience for this is people living in New York City and Long Island. We call them uninsured or underinsured. There's folks that have a deductible that's $5,000 a year, but they only make $20,000 a year. So that's more than 10% of their income. You have insurance, but we put you under underinsured because how the heck are you going to give out $5,000 before Health First picks up the tab? Single and single parents. A lot of parents, they put their children in the Child Health Plus plan, and they stayed uninsured. And we had to educate them that, no, you can also get insurance now as well, and keep it split. So you didn't have to put your child on your own plan and actually pay more money because the Child Health Plus plan was cheaper. And then you can see the incomes. One of the things we've learned greatly is it's very, at this level, 138 to 250, which is about $15,000 to $25,000 a year. What we learned is you can't speak to folks in the terminology of do you make $15,000 a year, because at this income range, they have multiple jobs, they have multiple part-time jobs, and so they talk in terms of how much I make per week, how much I make per month, and you got to whip out your calculator and times it to figure out what buckets they fall, to figure out their subsidies. So those were some of the things we did that were culturally relevant to this population to get them enrolled. When they heard commercials that said $25,000 a year, they said, oh, I don't make that. But if you added up all their W-2s, because they worked at UPS in the fall, they worked at a golf course in the summer, they were at a doctor's office on Mondays and Thursdays, they did McDonald's for a couple of months. If you added up all those W-2s, they did make $25,000 a year. But when they heard the commercial that said $25,000, they said, that's not me. I make too little. So that's where we bring some cultural competency into signing up. And I spoke about the languages, Urdu, Creole, Hindu. I'm learning a little bit. I'm Haitian. My Creole is getting a little better. I was with George Holtz in Haiti last summer. And then all the different ethnicities. And we purposely put first generation and second generation immigrant populations. So the good news is you see it, because when you typed it in, you found us. That was awesome, and we didn't plan that. So we do focus on that population because when they do come, they are looking for resources, and they're looking for culturally competent resources, and we try to be that beacon of hope for them. So this is the lessons we've learned as a health plan. I think we've grown up. We're probably 42. We doubled our age in 1 year. That consumerism is here. I don't have to say anything because we had a whole presentation about consumerism, so that's awesome. Access and availability is vital. So just because you enrolled a person you have to ensure that the doctors are able to take the patient. We work with our doctors. The worst thing to ever do is get them enrolled, and then they try to call for a physician, and all the panels are closed, or the doctor is like, I'm not seeing new patients. So we ensure that the patients that we assign doctors to are actually accepting new patients, and that the doctors match the patient demographic that we have. So, like we said, if someone needs to see a female doctor because of religious background, of religious concerns, that they can have enough female doctors in their neighborhood that's culturally competent to see. Facilitated enrollment leads to customer satisfaction. So we actually do a lot of surveys, and I pointed out the guys that were out there as pioneers telling us on the street, like the things that we can improve every day. We did a survey, and the folks that found us and enrolled on their own versus the folks that had a facilitated enrollment where someone actually brought an iPad to their house and walked them through it and maybe translated the English-only website, the differences was excellent to very satisfied versus good and average. So when we were there holding their hand through the enrollment process, customer satisfaction jumped up. And so we are very proud of our facilitated enrollment program. We have over 200 reps in the field across everywhere, and they take it as a real badge of honor to be able to represent Health First and help people get coverage. And then we talked about surveys. I can't harp enough. Every quarter we do surveys. We get 100 people. We try to invite them to 100 Church Street. If they don't come to our corporate office, we bring them to our community office. We have over 8 around the 5 boroughs. And we sit down with them and say, what didn't you like? You know, and they usually are shy, and they say, no, we love you guys. And then I'm like, okay, after the formalities, what didn't you like? And then they start bringing out letters and papers and things, and they say, you know, I got this, I got that, and we really take that information to heart and try to improve upon it so that it doesn't happen again. Keep it simple. There's so much complexity. APTC, Advanced Premium Tax Credit, CSR, Cost Sharing Reduction. These are terminologies that you'll hear on Fox News and MSNBC. It means nothing to the uninsured population. So instead of saying APTC and Cost Sharing Reduction, we call it financial assistance, because it's something that someone can relate to. Oh, like college. Yes, like college. We will help you with the cost of insurance. So keeping it very simple. We make sure all of our messages are at an 8th grade reading level or lower. And that's even with words like deductible and prior authorization, which we have to put in the letters. Even with those words in there, it's still 8th grade or lower. Over-communicate. You cannot communicate less. Consistent communication, because people will say they forgot or they didn't realize it. And then one thing I do want to harp on, especially for the navigators, I know there's one from Lutheran, is the physician networks. So you will find that there's Medicaid, Child Health Plus, commercial plans on the exchange. Not every plan has the same network for every product. You may call a doctor's office and say, do you accept Aetna? Do you accept Health First? You have to dig deeper. If they say yes, you have to say, is that Medicare? Is that commercial? Is that Child Health Plus? Is that Medicaid? And then call back again and ask the same question, because you may get a different answer. We've learned that there's so much confusion around patients finding out if the doctor's in the network. You've seen it on the news. So we do a lot of due diligence to make sure that when the patient chooses a doctor, it's a doctor that accepts their insurance and their product. And I'm going to speed through our marketing lessons because a lot of it has been said. What's in it for me? When we did health fairs, the word health fair didn't really work. But when we did, community events, and community events had face painters, massage therapists, we had DJs, hip hop aerobics artists, people showed up. So you can't really say, hey, insurance, sign up, come, like you'll hear crickets. You really have to do something that engages the community and gets them out. Prepare for procrastination. I loved your Google Trends lookup. The spike was the end of open enrollment. Everyone procrastinated. Young people procrastinate, right? They do their homework the day before it's due. So on March 31st, we had folks signing up people at midnight to get in before the open enrollment ended. So on November 15th, everyone's ready. And like the phone doesn't ring. And you're like, but is November 15th really the date? Does the open enrollment start today? It's like, yes, it starts today, but everyone's gonna procrastinate. So prepare for the procrastination. Make sure that you're ready for 200% increase in production on the last day. That's February 15th. So you're not gonna enjoy your Valentine's Day. Just prepare now. Give the flower on the 10th, because you're gonna be busy for the next 5 days. Open enrollment is for qualified health plans only. What leads to the procrastination is Medicaid, Child Health Plus, and other Medicare folks show up trying to sign up on that last day, even though the Medicaid and Child Health Plus people can come tomorrow. They can sign up on February 16th, February 17th, February 18th. So it's important when you say open enrollment, you specify what it means. It's for people making above 16,000, and children can enroll every month, and if they make below 16,000, they can enroll every month as well. So I think last year, the market and the industry spent all of their time on enrolling. Enroll, enroll, enroll. I need your tax documents. Enroll, enroll, enroll. And we never talked about the benefits. About 100% of preventive care is free, right? You can get annual physicals, checkups, mammogram screenings, child visits, all for free, even if you have a big deductible. Preventive care, based on your age and status, is free of charge in all ACA plans. There's a free gym membership. I'm leaving in 2 seconds. There's a free gym membership. We actually give people $400 if they go to the gym, you know, and we have to talk about the real good things about the benefits as well. Enrollment process is bumpy. The website is 10 times better than it was last year, but it's always good to set expectations so members know. At the bare minimum, it's going to take 15 days. So after they press send and it gets to the healthcare plan, they shouldn't call the healthcare plan that day and say, I didn't get my ID card. It's going to take some time. We talked about refer a friend. 93% of our members would refer us to a friend. Refer a friend is powerful, right? So all of you guys, on average, have 7 friends. Talk about what you learned tonight to other folks. And then I can't talk about it more, leverage social media. New York State of Health actually has a web chat function. And they have a Twitter page and a Facebook page. And during open enrollment, they put tips. So it's based on the phone calls they get for complaints, they start putting on Twitter and Facebook, hey, if you're enrolling and this is your situation, try this, try that. And so looking at that gives you lots of hints. And then I will leave with, these are our goals for 2015 as a health plan. We always want 90% of our people to say they had a good to great enrollment experience. I want everyone to have an ID card on time so there's no access to care. I want people to see their PCP. They need to know who their PCP is, visit the person, get a preventive care visit, use your gym reimbursement benefit, pay your premium online. You don't have to mail a check. You can pay faster, and then picking up the phone in 30 seconds. That's a big deal because if they don't get, if it rings and rings and rings, they hang up and they don't call you back. And that one question could be stopping someone from going to emergency room. And with that, thank you.
So, given that I know you're all hungry, so what I'm going to do is I'm going to ask you to go next door, get something to eat, bring it into this room. The panel will be here. You can still ask them questions, and they also can eat. How's that sound? Okay? Great. So let's just kind of adjourn for like 5 minutes so we can make sure we can get some hot food.
Yes.
I'm gonna have to leave it.
30 years